You want to just do it? All right. Hello and welcome to the Spine and Nerve Podcast. My name is Dr. Brian Joves.
Hi, I'm Dr. Julie Hastings.
And as you can hear, that is Dr. Hastings joining me today. We are going to be getting an introduction to chronic pelvic pain. So I cannot wait to learn about what you have to share with us, Dr. Hastings.
Thank you so much. I'm excited to share. This is going to be a pretty basic overview of chronic pelvic pain or persistent pelvic pain. As you can imagine, it's a very complicated, involved topic that definitely deserves more than a 30-minute intro. But I think for those of us who are not very familiar with chronic pelvic pain or not familiar at all, I think it should hopefully be a nice intro and kind of get you thinking and familiarize with how these patients may present, and in the very beginning of how to evaluate them and guide them for the treatment plan.
I think that's awesome. I think I can hopefully speak for much of our audience in saying that I appreciate you starting at the beginning, and I know that you'll take us much deeper into the realm of understanding as we progress through this little educational series you're going to bring us on.
Definitely. So I'll just go ahead and start. I have this PowerPoint that I gave to our providers in December of this year. So I'm going to be, or December of last year. So I'll be basing what I'm talking about on this. So there's some visuals as well. But Dr. Joves, I'd hop in with questions, okay?
Absolutely. And that's also a good point to tell everybody that we have a YouTube channel if you have not seen us in person or seen us in video format. So this would be the perfect reason to head on over to the YouTube channel, subscribe, and to be able to see the visuals that Dr. Hastings is going to use to accompany this week's episode.
Obviously is easy to follow with without the visuals as well, since I know most people will be listening to this in podcast form. Okay, so to start, well, what is pelvic pain? So pelvic pain may involve the visceral or the somatic system and encompasses structures supplied by the nervous system from the T10 thoracic spinal level and below. And what that really means is anything from, the bottom of the rib cage to really the mid thigh or top of the knee is often considered to be included in the realm of pelvic pain. And when we're looking at chronic pelvic pain, or what's defined as chronic pelvic pain, we're generally considering a non-malignant pain or not associated with malignancy, pain that's present for greater than 6 months. It can have a sudden or gradual onset. It is often associated with other somatic pain syndromes. And typically, to be defined as chronic pelvic pain, the pain is not exclusively associated with intercourse or menstruation. And so the epidemiology of chronic pelvic pain is, so these are some older statistics, but they, when I've looked at the more recent statistics, it's fairly similar that, up to a quarter of women of reproductive age experience pelvic pain. And many men experience pelvic pain too. And they're, people across the gender spectrum experience pelvic pain. But for focus sakes today, we'll be focusing on the pelvic pain of patients with vulvas, vaginas, uteruses. So, normal pelvic function requires coordinated activity of many different organ systems, including MSK, connective tissue, the viscera, and neural tissues of the pelvis. And dysfunction in any of these areas can create pain. So there's often not a single source of dysfunction, and it can be really challenging to tease apart the initial pain generator. And while patients often want to know, like, how did this start? It's often not necessary to really figure out how it started to be able to start effective treatment. And the way I often explain this to patients is it's kind of like an onion, and we just have to start peeling away at the layers by trying different diagnostics, different imaging, different labs, et cetera, trying different treatment methods, and that will help us kind of peel away the layers until we can get to really the core of the pelvic pain and treat it most effectively. So with pelvic pain, there's a multifactorial etiology. There's a very heterogeneous presentation. These patients often have multiple physicians who've seen them for the pelvic pain, and opinions from specialty to specialty, and even physician to physician within the same specialty can be quite varied. And, the cause of chronic pelvic pain is difficult to diagnose, partly because the pain symptoms may be the result of complex interactions between multiple body systems. So urologic, gyne, endocrine, GI, musculoskeletal, psych, etc. But the MSK system is often not considered until after patients have been to a number of specialists in order to obtain a diagnosis and treatment. I think more and more providers are looking at the musculoskeletal or neuromusculoskeletal system as a potential pain generator in pelvic pain, but it's more recent, still usually lags behind evaluation of other systems. So, pelvic pain falls into the category of chronic overlapping pain conditions, which includes chronic low back pain, chronic headache, TMJ, irritable bowel, fibromyalgia, chronic fatigue syndrome. And as anyone who experiences as a patient or treats these conditions as a provider, we're well aware that these conditions can be difficult to diagnose, difficult to treat, and extremely difficult to cure, which is frustrating for both the patient and the provider. It's okay to acknowledge that this is difficult and it can be frustrating. Oftentimes the best thing to do is just, you don't have to answer all the questions, as the patient or as the provider right off the bat, but, just always trying to take the next best step. So the etiology of chronic pelvic pain can be, I just kind of zipped along. Can be gastrointestinal, gynecologic, urologic, musculoskeletal, psych, and these can overlap. So at least 25 to 50% of patients have greater than one diagnosis. And the severity and consistency of pain often is increased with multi-system symptoms. And because of this, treating pelvic pain effectively often takes a multidisciplinary team and communication and collaboration with other providers. Providers outside of our field of physiatry also have a crucial role in ruling out more sinister causes of pelvic pain, such as infectious causes, for example, pelvic inflammatory disease, as well as cancers.
So Dr. Hastings, can you do me a favor? Can you explain to me a little bit more how, I said, because of your background in this, how the patients generally kind of presented in that multidisciplinary setting? And obviously I know you brought up, they've seen multiple providers. I mean, I know for, historically in a pure outpatient PM&R pain practice, by the time somebody makes it, to me, or that I've seen them, they've been through everything. But you had a very different setup with kind of your background. So how did those patients generally find their way to you?
And it was a tertiary care center or really tertiary referral center. So oftentimes the patients we saw there had also been through everything, and this was kind of their last, their last stop or their almost last hope. But in other settings that I've been in, patients can present kind of a myriad of ways. There can be lower abdominal pain, there can be perineal, rectal pain, there can be pain that only occurs with penetration, so that'd be dyspareunia. So that penetration can be with intercourse, with pelvic exams, with inserting a tampon, etc. There can also be a sensation of what feels like a UTI. Patients continue repeatedly present to their patients complaining of symptoms of UTI, but the urinary culture, or in male patients, presents like a prostatitis, but the urine culture or the prostate fluid culture continues to be negative. So there's no actual organism or infection, but the symptoms mimic that of an infection. So I would say those are the most common presentations that I've seen. But again, there can be a spectrum. It can be this nagging low back pain that hasn't responded to other treatment modalities. It can be like a feeling of heaviness in the pelvis, for example. It can be, within the umbrella of pelvic floor dysfunction falls pelvic pain, but with pelvic floor dysfunction, in general, there's not always pain. It can be symptoms of difficulty starting a stream of urine, weak urine stream, frequent urination with incomplete emptying. Constipation can be due to pelvic floor dysfunction. So really, it's broad, but that's generally, a combination of those presentations. Okay, so moving along, when you're in musculoskeletal medicine like we are, it's crucial to have an appropriate evaluation by specialists, as I mentioned, to rule out any kind of more sinister causes of pelvic pain or causes that need to be treated other than treating the neuromusculoskeletal system. So patients should undergo a PAP, STI testing, wet mount, UA, urine culture, pregnancy test, CBC, pelvic ultrasound, and then as appropriate, imaging, endometrial biopsy, cystoscopy, urodynamics, and again, as appropriate, colonoscopy or even laparoscopy would indicate it. So we'll briefly go through the differential diagnosis of persistent pelvic pain, focusing on the most frequently seen or most common causes. So with cyclical, so we'll start with gynecologic conditions. So under the umbrella of cyclical conditions, we have endometriosis, primary dysmenorrhea, adenomyosis, pain with ovulation, stenosis of the cervix, and ovarian remnant syndrome. Non-cyclical causes include pelvic inflammatory disease, pelvic congestion syndrome, pelvic masses, adhesive disease, vaginismus, and symptomatic pelvic organ prolapse. So this is a huge topic. So I almost feel like this brief of a summary is doing it a disservice, but I think the more providers who are even familiar with endometriosis, the better, because it's such an underdiagnosed and undertreated condition that really causes a lot of morbidity in patients who have endometriosis. So it's defined as the presence of endometrial tissue outside of the uterine cavity. And the etiology is not typically well understood. It's often diagnosed in younger women, 25 to 35 years of age. There's an increased risk with family history, and endometriosis is found in approximately 40% of women with infertility. It's most often found in dependent areas of the pelvis, such as the ovaries, posterior cul-de-sac, uterosacral ligaments, but endometrial deposits can be found all over, including the bowel, bladder, even the lung, skin, pleura, even on nerves, such as, the sciatic nerve can also have endometrial deposits. So they can really pop up everywhere. It's really impressive. As I mentioned, etiology is not well understood, but some thoughts are that it's a immunologic condition caused by retrograde menstruation, that there's lymphatic or hematologic spread of menstrual tissue, or a metaplasia of the epithelium. So symptoms of endometriosis can include dysmenorrhea, so pain with menstruation, dyspareunia or pain with penetration, infertility, as well as spotting between menses, so intermenstrual spotting, pain with defecation, pelvic heaviness, and it can even be asymptomatic and just diagnosed as part of a infertility workup. It is important to note, though, that the symptoms are not well correlated with the extent of disease. So there's often pain out of proportion to the physical exam findings or radiologic findings. Diagnosis can be made on clinical history and exam. And imaging studies are not often helpful because they often lack sufficient resolution to detect the small endometrial implants, which can be quite symptomatic. Really, the gold standard for diagnosis is exploratory laparoscopy. I apologize for my cough. As Dr. Joves knows, I'm experiencing a little bit of a post-COVID cough, so forgive me. But that's go listen to our long COVID, podcast for more information. All right.
You're getting good at plugging the other podcasts.
Now that plugs over, I'm going to take a sip of water and Okay, even mild COVID, guys, I would not recommend it. It's not that mild. All right, so primary dysmenorrhea is pain associated with menses, typically onsets 1 to 3 days prior to the onset of menses. These patients are often young, often experience a heavy menstrual flow, and there is association with nulliparity, so someone who has not experienced pregnancy or childbirth, as well as cigarette smoking. This pain is often crampy abdominal pain and can include nausea, vomiting, diarrhea, and headache. These patients often have a normal physical exam. And then we have pelvic inflammatory disease, which includes a spectrum of inflammation and infection in the upper female genital tract. So it's really an ascending infection of vaginal or cervical microorganisms, including chlamydia, gonorrhea, in developing countries, tuberculosis, but it's typically a polymicrobial infection. And this can cause chronic pelvic pain in approximately 18 to 35% of women with pelvic inflammatory disease due to the inflammatory process involved in the development of adhesions. And, you know, this inflammatory process, not just with pelvic inflammatory disease, but with UTIs, yeast infections, bacterial vaginosis, can often be the inciting factor in chronic pelvic pain. And I don't know the numbers behind it, but in my clinical experience, you know, I did often see patients who had a UTI or a particularly bad yeast infection that was treated, you know, appropriately, and the infection went away, but the chronic pelvic pain or the sensation of the infection remained. So when we're looking at urologic conditions, there's a number of them, including urethral diverticulum, chronic UTI, radiation cystitis, bladder carcinoma, et cetera. But the most common seen in the persistent pelvic pain, you know, practices that I've been a part of is interstitial cystitis. And like endometriosis, this is, you know, a not very well understood condition. So interstitial cystitis is a chronic inflammatory condition of the bladder. It's thought to be due to the loss of mucosal surface protection by the bladder. So when you lose that mucin layer, or a breakdown of the mucin layer that lines the bladder, there's a subsequent increased bladder permeability, which causes basically, you know, urine, which normally sits in the bladder without pain, to become painful. So anytime there's urine in the bladder, it irritates the bladder wall and causes pain. So symptoms seen with that include urinary urgency and frequency. So basically, anytime there's urine in the bladder, even a little bit, it's uncomfortable and the patient wants to get it out. And this, you know, this with pelvic floor dysfunction as well, this urgency and frequency, the kind of the trademark of interstitial cystitis, as these patients have such pain with urine in the bladder that it wakes them up throughout the night. When patients have urinary urgency and frequency because of pelvic floor dysfunction, it usually does not occur overnight. They're usually able to sleep through the night. It's only when they're awake that they have this urgency and frequency. Gastrointestinal conditions, irritable bowel syndrome is a huge one, and one of those chronic overlapping pain conditions. Constipation, colon cancer, inflammatory bowel disease, colitis, chronic intermittent bowel obstruction, and diverticular disease. So irritable bowel syndrome is a chronic relapsing pattern of abdominopelvic pain and bowel dysfunction with diarrhea and or constipation. So this affects at least 12% of the population. And as I've mentioned multiple times, and will probably mention time and time again, these chronic overlapping pain conditions are often undiagnosed or underdiagnosed. So I really think 12% of the US population is an underestimate. That presents women 2 to 1 in women versus men, and is associated with elevated stress levels. So irritable bowel syndrome is diagnosed using the Rome 4 criteria for irritable bowel syndrome, and it usually includes dietary changes, addressing stress, cognitive psychotherapy, and medications such as TCAs or SSRIs, SNRIs. You know, more of our holistic medicine colleagues or naturopathic colleagues are also doing interesting work in ruling out in SIBO or other bacterial causes of irritable bowel syndrome. But I don't want to speak to that too much because it's not my area of expertise, but it is it is very interesting and could really help some of these patients who have tried, our more traditional Western medicine treatments for irritable bowel syndrome without success. So while we should never, I think one of the largest disservices that's been done to the chronic pelvic pain community over the years is people being told it's just in their head, or the pain, pain community in general. But, so I don't think we should never jump to this, but there's often a psychologic comorbidity or overlap with pelvic pain. And, it's really a chicken or the egg thing. I mean, if you're having persistent pelvic pain, it's likely to cause psychological distress, whether that's depression or anxiety or, medical PTSD. So, there are pelvic pain situations that are due to somatization disorder, potentially in situations of abuse. But, there's most often, if not always, more to the picture. And you can also see chronic pelvic pain with abdominal cutaneous nerve entrapment, such as surgical scar, post-cesarean or post-hernia surgery, as well as with celiac disease or porphyria.
Yeah, I think you brought up a really good point there. I think even within the pain community, right, where we know that generally, especially in the general public, there is this massive association of, of psychological comorbidities with all things chronic pain. But even within the pain community, I think there is especially this correlation or thought process that there's a significant amount of psychological and psychiatric overlap with pelvic pain. And so, obviously, like you said, it is such a big part of living with chronic pain for all people who live with chronic pain, no matter the location or underlying disease process. But, I think this is one area where, even sometimes our community tends to be a little bit overly skeptical, maybe is the right word or terminology.
I think most of our pelvic pain patients could benefit from a psychotherapeutic intervention. That being said, I think most of our pain patients could benefit from a psychotherapeutic intervention. And I think most of us, just as humans walking the earth, could benefit from a psychotherapeutic intervention. I mean, there's so many causes of stress and trauma. And if you're constantly living in pain that, greatly impacts your quality of life and not getting answers, not getting taken seriously, like how can there not be a degree of trauma associated with that? So
absolutely.
I think us trying to limit that as providers, limit our involvement in that, or just be mindful and non-judgmental in how we, approach our patients, as well as helping patients, acknowledge what they've been through and get the appropriate treatment for that is really important.
Absolutely.
Okay, so now that we're going more into kind of my realm of greater knowledge is with pelvic floor dysfunction or pelvic floor tension myalgia. There's many different names for this. So like I said, pelvic floor dysfunction, high tone pelvic floor dysfunction, pelvic floor pain, high tone pelvic floor myalgia, kind of any combination of those words is used to label this pain. But this may occur as a result of inherent musculoskeletal causes in the pelvic floor muscles, ligaments, and tendons, or it may occur as a functional adaptation to other disorders within the pelvis hip spine complex. So this can be due to direct injury, so with childbirth, trauma, surgery, radiation, as well as repetitive microtrauma, so overstretch or overuse injuries, poor posture, or maladaptive voiding and defecatory patterns that over time cause a responsive pelvic floor tension myalgia. So the diagnosis is based on history and physical exam. Physical exam often includes a vaginal or rectal exam, looking for pelvic floor muscle spasm and tenderness, taut myofascial bands, and trigger points, as well as abnormal pelvic floor muscle movement patterns or dyssynergia. And I'm trying to think in the interest of time what I can be more brief about, but so coccydynia is also falls under the umbrella neuromusculoskeletal pelvic pain and can be seen within pelvic floor dysfunction. This is defined as pain at or immediately surrounding the coccyx, which is aggravated by sitting or by transitional movements. There are a number of pelvic neuropathies that cause persistent pelvic pain, including pudendal neuralgia, iliohypogastric or ilioinguinal neuralgia, and genitofemoral neuralgia. Pudendal neuralgia tends to get a little more, a little more publicity than other pelvic pain causing conditions. And it's a tricky one. It's difficult to distinguish from overactive pelvic floor myofascial pain, as many patients with pudendal neuralgia develop reflexive overactivity of the pelvic floor. And, the nerve might actually not be entrapped, but instead be under kind of constant traction or compression of the pelvic floor muscles because of dynamic factors. Neuralgia is diagnosed by the NAMS criteria, which includes a number of inclusion or exclusion criteria that help diagnose pudendal neuralgia clinically, which is the best way to diagnose it. Other potential etiologies of persistent pelvic pain include lumbosacral spine pathology, intra-articular hip pathology. I think this is a huge one for musculoskeletal providers. I mean, a number of the pelvic floor muscles are also hip stabilizers. So when a patient has intra-articular hip pathology, you can definitely see associated pelvic floor dysfunction. I mean, I've seen I would say at least a handful of patients this symptom of UTI, so this lower abdominal bladder pain. But really, what we experience is bladder pain is overlying kind of somatically with the obturator muscles. The obturator muscles are hip stabilizers. So, it's important to evaluate these patients for femorotabular impingement, labral tears, or other intra-articular hip conditions that may be causing their symptoms. Kind of thinking holistically, I suppose, about the whole, the whole pelvic complex. And then treatment, there are a number of treatment options for pelvic floor dysfunction. The mainstay really is pelvic floor physical therapy. And you'll be hearing an interview with a pelvic floor physical therapist on our podcast. And I think she speaks to really eloquently what pelvic floor physical therapy looks like, who it can help, and how it can help. I think this is something that can benefit almost all of our pelvic floor patients, or pelvic pain patients. There's a number of medication options, so systemic medications or vaginal suppository medications, as well as injections, such as trigger point injections, botulinum toxin injections to the pelvic floor, as well as appropriate nerve blocks when indicated. I'm not speaking much to this in this talk, as it's kind of a newer area for me, but there's also a number of promising technologies as far as peripheral nerve stimulation when it comes to treating pelvic floor dysfunction, which is something I've started to learn about and look forward to learning more about in the future and kind of adding to our repertoire, because I think the more tools in our toolbox, the better, especially when treating these complex pain conditions.
Yeah, for sure. And I think our audience already knows our infatuation with neuromodulation at large. So it's another one of the amazing areas, of where we don't have maybe as many tools as we'd like that are now being explored with the use of technology.
Well, I think we'll leave it at that for today. I think that's a nice intro. Obviously, there's so much more that we can speak about, but I think kind of throughout this series of where we're talking about pelvic pain, we'll be able to explore some more of these topics in a little more detail and answer questions that people have.
And I think it was a great overview of just, maybe even just to understand just how complex this overall system is, right? To really get that there's so many different things that can present with, uncomfortable sensations in a anatomic region, which I think, when most people start thinking about pelvic pain, I'm not sure that everybody really necessarily thinks about it kind of quite as diverse as you just explained. And so thank you for that.
Thank you.
So let's kind of take a big, like 10,000 foot view of things and say, we're talking to, I don't know, a med student or maybe an intern who's, just starting up in outpatient clinic, and somebody is coming in and, they just listened and they're like, oh my gosh, there's 35 diagnoses that you just said. And you said, there's a lot more that I have to think about. But I don't really know, what I'm doing here. I know that they have pain and or discomfort or, these sensations that I don't really fully understand. Like what would be the first thing that you would want them to think about as they're seeing that patient coming in and trying to figure out how to make those correct steps to kind of move the ball forward for the patient?
First, I think a key first step with these patients is really taking a detailed history. When their symptoms occur, kind of asking about any symptoms involving intercourse, urination, defecation, patient surgical history, carefully asking about the patient's potential trauma or psychologic history, childbirth history, how this pain started, how this pain affects them. I think getting a really good sense of what they've been through diagnostically, like what's been ruled out, is almost as important as what we can rule in, as well as how the pain affects their function. I think that's a great place to start.
Awesome. I think that's amazing. Thank you. Well, I hope you guys all enjoyed listening to this. I hope you learned something. I know I did. I truly appreciate you, Dr. Hastings, for enlightening me and enlighten all of us and giving us a good place to start, right? And hopefully, as we continue through this, not only will we explore more of these topics, but we'll start to understand some of the ways that we can, continue to move the ball forward for these patients, get them options that will help them and, be able to make a difference in a community that, I 100% agree is massively underserved, under-identified, and hopefully we can, kind of do a lot for into the future.
Yes, definitely. Thank you so much.
All right, everybody, stay tuned for those legal disclaimers, and we will talk to you soon. Have a good one.